All righty. So it's good to see you all and welcome to our Project Echo Dementia. We'll just begin with a couple of remarks and reminders. We're going to bypass the introductions, as we know, and then we're very fortunate to have, Dr. Bonnie Kyung here to talk to us today about visual impairment and memory loss and a case exploration, which sounds very intriguing. So if you can, if you're able, we love to see your faces. Please enter into the chat if you're with a number of folks. Everybody who's attending from your site, please mute your microphone when you're not speaking and then say your name when you unmute. As I just said, turn the video on if you can, but we understand if you can't. We take very seriously HIPAA and protecting all private health information. So don't display anything or say anything that could reveal any personal information regarding patients or families. And let me remind you all that the sessions are recorded and available on the website. And please do take this literally less than a minute to complete the post-session survey, since that helps us to improve the content and the format and the process of this with the community in mind. So we have, it's incredible to think about this, but there are only 3 more sessions till the end of the year. So upcoming exciting sessions next by Dr. Carolyn Parsi. I'm not going to read the rest, but you see here, and reminders that in November and December, because of holidays, there's only 1 session per month, as you see on the slide. Again, we implore you, please bring your cases forward. It's an opportunity to really think together, to learn together, to probe deeper, to bring that collective process to the patient and family to deepen the knowledge and to improve the care. So reach out to Allison if you have a case. Thank you. We have accreditation through the School of Medicine and School of Nursing for CME and CNE. And we have nothing to disclose, no financial relationships with ineligible companies, nothing around off-brand marketing. And if there ever were somebody who was presenting who had some relevant financial relationship, we would mitigate these very seriously. Okay, we are the hub team. Most of us are here today. You represent a swath of Washington. We're continuing to broaden and build. So invite your colleagues and anybody who you think would potentially benefit from our programming, because we want to continue to grow the community to build and scale care for people living with dementia and their families where they are and by those who know them best. So thank you, Dr. Bonnie Kyung, for talking to us today. She's from Swedish Neuro-Ophthalmology. She brings a wealth of knowledge to us, and she's going to speak about visual impairment and memory loss, a case exploration. And I will stop my share. And then
are you seeing the
perfect.
Regular slides?
We are.
It looks perfect.
Okay. Let me just move this over here. So thank you for having me. And you may be, first of all, asking yourself what a neuro-ophthalmologist is, and that's fine. In the United States, neuro-ophthalmologist is either neurology or ophthalmology residency trained. And then they have following training in fellowship in neuro-ophthalmology, whether it be 1 year or 2 years, and there are many universities and big eye and neuroscience centers that have neuro-ophthalmology fellowship training. So the common things that we see include optic neuritis, papilledema, ischemic optic neuropathy, patients that present with nystagmus, double vision, presentations of ocular myasthenia, any form of compressive optic neuropathy. And then we also see patients presenting with symptoms related to an occipital lobe problem. So I just want to start off with not the main case, but a case that exemplifies vision loss related to occipital lobe problem. I saw a 66-year-old man with hypertension, hyperlipidemia, and coronary artery disease who suddenly noticed a left-sided visual field defect. He was seen in eye clinic where his eye exam was entirely normal, yet the visual field test, and this is an automated visual field test, showed a left inferior homonymous quadrant tenopia. So this localizes to the right occipital lobe, and his MRI showed a subacute, so it's been a couple days by now, but his MRI showed a subacute infarct in the right occipital lobe. So fortunately, this is quite simple. The visual field matches exactly the region of the visual field defect matches the region of the right posterior cerebral artery territory distribution. He had an infarct in that distribution. His workup included an outpatient Holter monitor that showed that he had atrial fibrillation. So fortunately, that was just really straightforward and simple. But one of my goals for this talk is to get to the point of talking about more rare diagnosis. And in fact, they're rare within the neuro-ophthalmology realm. But I wanted to get to the goal of talking about higher cortical vision loss in the setting of neurodegenerative disease. So the second case is a patient referred for visual field defect, yet a normal brain MRI. And she was referred by both her PCP and more than one ophthalmologist. So she is a 64-year-old woman and first complained about a 1-month duration of difficulty with driving home, and that vision was just non-specifically, quote, off. So understandably, she saw an ophthalmologist, and she told him in the documentation that things were just not right with focusing. Things looked weird. Some objects were bigger than they should, and some looked smaller. And the provider's assessment was that she had a small epiretinal membrane on the retina and potentially could have surgery to address this. She went on to see another ophthalmologist, and at that second appointment, it was discovered that she had a dense left homonymous hemianopia. So he promptly referred her to the emergency department to get a stroke workup. This is the visual field that he got, which showed a left homonymous hemianopia. She went to one of the Swedish emergency departments, and you can see on the diffusion weighted image on the very left side that there is no evidence of an acute stroke. I do acknowledge that there's general atrophy of the brain and that there's some level of dilation of the ventricles that could be related to the general brain atrophy. As you may know, the emergency room's goal is to really rule out stroke. And since there was no stroke, she understandably was sent home. So at that point, after kind of the inconclusive MRI results, she was referred to, or not informative MRI results, she was referred to neuro-ophthalmology clinic and saw me. And she was reporting progressive left-sided vision loss. She described cognitive decline for an unclear timeline, but also thought it could be attributed to all the anxiety around the vision loss. And there was no corroboration. She didn't have a family member with her. She described that she was getting lost in conversations, and she had no problems with recognizing faces, no visual or auditory hallucinations, and no episodes of change in consciousness. We repeated a visual field in clinic. This time we did a manual visual field. So the surface area that the lines encompass is the areas that she can see well. And again, this recreated a dense left homonymous hemianopia. I just wanted to just describe what normal is. So a normal visual field would have a surface area like a pie. You would see everything within that pie, and hers was half missing in the left homonymous hemianopia. So it had been no longer than 2 weeks, but I ended up ordering another MRI because clearly the visual field was localizing to the brain. And so this is her second MRI about two weeks later. And you can see, if you can you see my arrow okay here? Maybe not, but if down here in the occipital lobe, there's a little ribbon where there's increased signal. And so to the radiologist and to myself, the differential here includes, could there be an infection like encephalitis? Could this be post-ictal, like after seizure? I didn't get that story from him. And I think what was already concerning on my end was, could this be very early prion disease? So she went on to get a lumbar puncture that was very normal. There were 0 cells. The protein and the glucose were normal, and there was nothing spectacular in the gram stain. Her spinal fluid was sent off to the National Prion Disease Pathology Surveillance Center, and the result returned negative. So nowadays we send for a test called RT-QuIC, and it stands for real-time quaking induced conversion. And so the sample is actually, they actually shake it. And then the proteins break apart, the prion proteins break apart, and then enough so that it can be amplified. And the amount of misfolded prion proteins can be then detected. So it's considered to be a very highly sensitive and specific test, but her result came back negative, and you can see on the top part that they estimate the probability of prion disease to be 5%. So that wasn't super helpful, but in the meantime, over the month after I saw her, she continued to have cognitive decline. Her family was definitely involved now, and reporting that she was unable to hold a conversation. Eventually, she lost the ability to care for herself, and they were describing that she was essentially blind, and I believe cortically blind, and then needed pretty much needed 24-hour care. There's one more MRI in the system, and this is about 2 months after the first MRI, and now things are very clear. There's now significant interval progression of the cortical diffusion restriction. And even though it's asymmetric, there's bilateral involvement of both cerebral hemispheres, and the radiographic differential. Well, the radiologist was very highly suspicious on his end that this looked radiographically like Creutzfeldt-Jakob disease, specifically looking back at the other MRIs, that it probably was the Heidenhain variant, where the disease starts off in the posterior part of the brain. So this MRI, especially if you look at the posterior parts of the MRI near the occipital lobes, makes you understand why towards the end she did end up becoming cortically blind. And then on autopsy, the results showed that she, on immunostaining, that she had monoclonal antibodies to, I think I spelled it wrong, the prion protein, making her final diagnosis, Creutzfeldt-Jakob disease. So my intent of this talk is not to talk about CJD or Creutzfeldt-Jakob, but just very briefly, it's a rapidly progressive fatal neurodegenerative disorder, and it's quite rare. But if you work at a large hospital or institution, it's going to come up once or twice a year, potentially as an inpatient initially. And the etiology is caused by a transformation from a normal glycoprotein into an abnormal glycoprotein that then spreads. And it commonly occurs sporadically, and it can present first with cortical vision loss, and that's called the Heidenhain variant. And the diagnosis is made clinically with rapidly progressive cognitive decline, and the testing of the CSF with the RT-QuIC. There's other supporting features like the MRI features that I showed you, and the EEG can also be helpful. And unfortunately, there's no treatment for this. So I presented a very much zebra case, like a super zebra case. Most of the cortical vision loss comes in the form of the first case, where it's like a occipital infarct. And other presentations include intraparenchymal hemorrhage, occipital mass or a vascular mass in the occipital lobe. Posterior reversible encephalopathy syndrome is another presentation of cortical visual dysfunction. And by definition, that should be reversible. And then finally, I've seen cases of hypoxic ischemic injury where people recover very nicely, but then their only residual symptom is cortical visual loss. So I want to highlight that visual impairment and problems in the cortex may not be as simple as a homonymous visual field defect. And the patients can have presentations that stem from lesions in the visual association cortex. So the first case not only had the second case, the last case, not only had originally the pure visual field occipital lobe defect, but then she went on to have problems in the higher cortical visual area. And then I want to highlight that there's also an Alzheimer's variant where patients can present initially with vision symptoms related to the visual association cortex rather than the primary visual cortex. And it's called posterior cortical atrophy because the degeneration first occurs in the posterior region of the brain. The goal is to kind of get insight into higher cortical vision loss, but in order to get there, I think I do want to review the visual pathway. So the visual pathway is the route by which the retinal stimuli is transferred to the occipital cortex of the brain. So it encompasses the retina, the optic nerve, the optic chiasm, the optic radiation, and finally the visual center in the occipital lobes. So first, the photoreceptors in the retina, they're stimulated by light entering the eye, and then the photoreceptors synapse with cells called the retinal ganglion cells, and these ganglion cells then converge on the optic disc, forming the optic nerve. Then the optic nerve is responsible for transmitting the information for vision, and then once inside the skull, the optic nerve travels on the floor of the middle cranial fossa, and then the left and the right optic nerve converge at the chiasm. And so this chiasm is right above the pituitary gland, and you may remember that when a patient has a pituitary tumor compressing the chiasm, you could get a bitemporal hemianopia. And then at this chiasm, the fibers from the nasal aspect of the retina cross over to the other side of the optic tract. And then the fibers from the temporal retina remain on their respective sides. And in this way, left-sided post-chiasmal fibers pertain to the right side of the visual field, and then vice versa. And finally, the optic tracts extend from the chiasm to the thalamus, and this is the last synapse with the second order sensory neurons at the lateral geniculate nucleus in the thalamus. And from here, the nerves radiate dorsally to the calcarine sulcus of the occipital lobe, and this is where primary visual cortex, where basic raw vision is housed and processed. So once you've figured out the problem is right here in the primary visual cortex, or if you want to map it out, I guess the question is how would you do it? I'm not sure if I can share this video. How is my time right now?
You can take as much time as you need.
Okay.
You have plenty of time. Thank you for asking.
I think I have to
Maybe
stop the share and then share again. let me know if this doesn't work. I'm okay with maybe the sound not working. But just first at bedside, if you're suspicious for a visual field defect that stems from the occipital lobe, one would do confrontation visual field testing at
Sorry, Bonnie,
bedside.
we don't see anything yet. I just want to
Okay.
clarify. I didn't know if you thought we did.
Oh, I didn't press share yet. So
Okay.
this
Okay, there we
is
go.
a
Perfect. Great.
video from University of Iowa in their eye center website. Can you hear anything?
We can read, no, but we can see her lips.
So just to summarize I don't think you heard everything. I basically stand right in front of the patient, like this provider did, and I cover my eye. Like if I'm testing their right eye, I'm gonna cover my left. Sorry, if I want to test their left eye, then I'm gonna cover my left eye as well, my left eye, and so like we're on the equal plane. And what I do is I either use 1, 2, or 5 just to keep it simple, and I just test all of the 4 quadrants in the periphery and then right down the center. And that's what the stroke docs do also when they do the NIH stroke scale in the ER when there's a suspicion that somebody has a stroke. So that's something that you can do right at bedside. And I'm going to try to share back. So stop share and then share again. How's that? Am I back?
You're back.
Okay.
Perfect.
And it might seem really simplistic, but you can get a lot of information from that just at bedside. And if you wanted to have more detail, you can do standard automated perimetry. So automated visual perimetry is very ubiquitous amongst eye clinics, whether they be optometry or ophthalmology clinics. Usually the clinics do have to set aside some extra time to do this because it takes about 3 to 5 minutes per eye in a very alert patient. And of course, the pattern is very helpful. It can tell eye providers whether a patient has glaucoma. And of course, the pattern is helpful in localizing the lesion and showing if the problem arises from the brain. And so the advantage of automated perimetry is that you can always compare apples to apples. Almost everybody has similar software. So the results are reproducible. And this is the example from the very first case that I gave you where the patient had the left inferior homonymous quadrant tenopia. In our clinic in our neuro-ophthalmology clinic, we also have manual perimetry. And this works best for individuals who just cannot do automated perimetry. Examples include younger people, like children. Their attention isn't there to stick with it for a visual field. This is also beneficial when the patient's vision isn't good. And usually I start to think about doing manual perimetry when the vision is worse than 2150 or closer to 2200. And then understandably, it works well for patients with impaired cognition. And the technician on the other side can kind of cater to the patient's attention and like pause and give breaks in between, and looking through this telescope can see where their eyes are, if they're moving around or if they're kind of sticking with it. So it can be helpful in a certain subset of patients. So now that we've laid the groundwork for the primary visual cortex, I wanted to describe that from the occipital visual center, the signals are then sent to either the frontal, parietal, or temporal lobes. to further make sense of the input of visual information. So this includes reading and facial recognition. And so after the initial processing of the primary visual cortex, which receives the raw information, all these adjacent cortical structures continue to work on analyzing aspects of visual information. And to simplify things, there are two major pathways. The first pathway is the what pathway. Let's see if it'll pop up. Otherwise known as the ventral stream pathway, from the occipital lobes to the temporal lobes. And this region is involved in analyzing the recognition of an object. So this region helps with discerning color, recognizing facial patterns, and shape recognition. The other pathway is the where pathway, and it's the dorsal stream. And the where pathway is the stream from the occipital lobe to the parietal lobes. And this region helps with locating objects in space and how the body acts on objects. So we need to analyze objects in comparison to our body and in space. And this area discerns kind of the action of vision. So it helps with analyzing moving objects, helps with discerning how the body is moving in comparison to the object. And then finally, this area is also involved in attention. So for instance, which objects are important in a scene and how to prioritize visual information. So when there's a problem in this where, how pathway, patients have they actually don't necessarily have a problem with recognition of the object, but they have a problem acting on the object in their 3D space. So I took these cases from the neurology continuum section. They had some nice, concise cases, and there were two cases I wanted to share. One is a 70-year-old woman who presented to neurology clinic with difficulty reaching for things like forks and cups. She was able to read individual words at a time, but had difficulty moving from word to word and sentence to sentence. And then finally, she had lots of confusion when put in a busy setting like a big supermarket. So her examination showed normal vision, normal ocular exam, but her neurologic exam was significant for inaccurate reaching for objects, which is called optic ataxia. She had inaccurate eye movements when searching for objects in the room. That's called optic apraxia. And then finally, she had simultanagnosia. And all three of these things in bold, optic ataxia, optic apraxia, and simultanagnosia, are part of something called Bolintz syndrome. I wanted to spend a little bit of time talking about simultanagnosia. It's basically the inability to perceive more than one object at a time. And patients with simultanagnosia are able to see local elements of the scene, but not the global elements in their totality. So in other words, they're kind of like missing the forest for the tree. And these are three examples that you can actually get online. Patients with simultanagnosia will see these overlapping figures, but only be able to pick out one or two of the objects and not everything altogether. With the vegetable man or the fruit man, a patient with simultanagnosia will see the fruits or the flowers, but not see that they all make up a man, a bearded man. And then the last one is that a patient might see only the E's and point them out, but not be able to see that the whole thing in totality is actually showing an A. So that patient that I described had an MRI that showed quite significant atrophy of the posterior parietal and occipital regions, and that led to the diagnosis of posterior cerebral atrophy. And so I don't know if you've reviewed this before in other talks, but posterior cortical atrophy is a variant presentation of Alzheimer's dementia where the degeneration initially has a predilection for the posterior regions rather than more classically the temporal lobes. And due to the bilateral parietal occipital lobes being affected, the patients can have symptoms that arise from this dorsal pathway, and it manifests as having trouble figuring out where objects are in space, which is why she was kind of reaching for objects all wrong. They'll have problems with where the body is compared to the object, and also problems with acting and keeping attention on what is important and maintaining attention. And then this last case, also from the series of cases in the Neurology Journal, is a 37-year-old woman who was having difficulty distinguishing faces. And she described that faces were smoother than usual, and it looked like people had like an Instagram filter over them. And her exam showed normal visual acuity and normal ocular examination. And she also had normal visual field testing, but it was evident that she had difficulty recognizing faces. So what I do in clinic, if I'm concerned about difficulty with facial recognition, is that I just, honestly, I should have like a whole file of faces, but I just go online and like look up some famous faces. And if people have prosopagnosia, they'll have difficulty recognizing faces that you'd think that they would recognize. This particular patient had a metastatic lesion in the medial aspect of the right temporal lobe, and this was eventually resected in the second image. So this lesion disrupts an area that processes faces in the what pathway. So there's many other higher cortical visual disorders that you can kind of get lost in and read about. I just listed a few of them, and I kind of gave you just the highlights of 2 of them. So if you have any interest, you can definitely read more about it. So after all of those cases, in conclusion, we looked at the fact that occipital lobe lesions can be very easily detected with visual field testing. And for instance, a right homonymous quadrant tenopia would localize very nicely to the left occipital lobe. A very common presentation would be an occipital lobe stroke, but there are other things that can happen. We looked at a very unique case where the patient presented with vision loss, a left homonymous hemianopia, and she ended up having CJD. There's also the presentation of posterior cortical atrophy in Alzheimer's disease. Another important lesson is that sometimes lesions aren't first seen on the MRI. So in that case that I described, her original MRI was considered to be normal, but the visual field testing suggested otherwise. And so if there's a high suspicion that something is going on in the brain, it's important to get expert re-review and see if somebody can take another look at things. And then finally, I was hoping to challenge you to think outside of just the primary visual cortex into the higher cortical visual disorders. And we talked about 2 different cases, one with Balint syndrome and one with prosopagnosia. So I hope that's somewhat challenging, but also very interesting. That's the end of my talk.